too. Yeah.
And then stepped back and started outpatient when she moved to Texas. So that's how I met you.
Awesome. Yeah. Thanks.
We're excited to have you.
Awesome. Thank you.
And I didn't know if you wanted to.
Oh, thank you.
The one I emailed last week, I caught a couple grammatical errors, so I was like, I gotta redo it. And I don't know if you guys had a chance to read. I was kind of perusing some notes last night and found a much better article on CBT and eating disorders, so I emailed it really fast and said, so I know you guys probably have not had a chance to read it, but that's actually a much better, actually what I'll be doing today is probably more of a summary of all of that, and then that article goes into like way more detail and everything, so I apologize for that last minute change, but at this point, at least you have, some good stuff on CBT and eating disorders, so yeah. Lecturing is not really my thing, so if I need to slow down or speed up or move along or whatever, feel free to just give me a little cue. I am not offended in the least, and if you're like me, it's kind of better to ask questions in the moment because I'm not going to remember them at the end, so feel free to just interrupt me and ask a question. Just kind of as we go along. I kind of structured the presentation to give you kind of an overview of eating disorders and what they look like in the beginning, and then I'll kind of transition a little bit more into what it looks like to do cognitive behavioral therapy with eating disorders. One little caveat is, as I'm going through a lot of this, there's really kind of a manual-based approach, manual-based CBT to use with eating disorders. I don't do like a strict manual-based approach. I kind of do a little bit more of a modified approach, and which to me is, I think, as I'm reading through all of this, going, why do I do that? I think I'm just realizing that some of it's a little bit more difficult on an outpatient basis as far as some of the CBT model, but I'll tell you what I know, I'm sure others do it differently at times. So, okay, let me, all right, that's just me. So, how I went to this presentation at a conference earlier this year on, I think, OCD and anorexia nervosa, and the presenter kind of started off saying, we all have our little quirks, right? And he went on to say that one of his is like he cannot stand it when DSM, 5 is with a Roman numeral instead of the correct numerical 5. So I have a couple of little, quirks when it comes to eating disorder diagnoses, and so that's kind of why I wanted to paint a picture here of what it really looks like. One of the bigger quirks that I have is either when, not so much a client, but like if another professional says, oh, she has anorexia and bulimia, that just kind of gets me because you cannot have both at the same time. Anorexia will trump bulimia any day of the week, so you have one or the other. Not to say that you can't have one and then the other at another point in life, but you don't have anorexia and bulimia at the same time. So anyway, I'm kind of getting ahead of myself, but let me just go through this. Also, this is not timed, so my goal, I have not, I should say, practiced the timing. My goal is just kind of go through this, keep track of time. I'm definitely going to leave some time for questions at the end, just as we go. So, anorexia nervosa, we all, I think, kind of picture, typically probably like an adolescent girl, maybe young adult woman who kind of has that really gaunt look about her, very sickly, kind of what the media portrays as a very extreme example of anorexia nervosa. The reality is that you could have someone come into your office or your clinic or wherever who looks pretty normal, maybe kind of the low side of normal, who actually is deeply entrenched in anorexia nervosa. So, when it comes to some of this, never judge a book by its cover, Anorexia, of course, from DSM-5, they made a couple of changes from DSM-4-TR, but the main one, of course, is restriction of energy intake, leading to significantly low body weight or less than minimally normal or expected. That in particular might be a little bit more for an adolescent. So maybe an adolescent or a child doesn't so much lose a ton of weight as much as it is they do not progress forward on their growth chart and that kind of thing. I typically refer to this as just restriction and low body weight. Low body weight can also be different things, for we all have different genetics and different body compositions. And so for someone who's, say, 5'6", 115 might be an incredibly low body weight for that person, whereas someone else with different genetics and that kind of thing, maybe 100 is more of her low body weight. I should say very low body weight. So we're all kind of different as far as what low body weight is. In the DSM-4, they had kind of a suggested 85% or less than, the less than 85% of what would be expected for that person. So they've taken out the 85%, and that was really more just meant to be like a guideline, not like a hard and fast rule, but we kind of took it that way. So they took that out and just kind of worded it like this. Second criteria is intense fear of gaining weight or of becoming fat, or persistent behavior that interferes with weight gain, even though at a significantly low weight. I feel like the first one, intense fear of gaining weight, that's, again, I think what society portrays as kind of the norm for anorexia. But I really want to kind of highlight the last couple there, because not everyone with anorexia really desires to lose a lot of weight and get skinnier and skinnier and skinnier. And many times that's not really it. That's not their intent. But what ends up happening is that they ignore so many of the cues going on, so many of the medical issues, psychological, emotional issues, that come from having a low body weight, because they are afraid of becoming fat. So they may very much acknowledge, yes, I know I'm underweight. Yes, I know I'm malnourished, but I can't do this. I can't gain weight, So it sometimes might be a little bit more than that. Others, persistent behaviors that interfere with weight gain, so those are sometimes individuals who, I've had a couple like this in the last year, who they're kind of more, what would I call it? I'm not aloof, but there's a word that's I'm missing. That's when you're kind of maybe oblivious is kind of what it is. Just individuals who are quite a bit more oblivious to their hunger signals, how much they've eaten that day, how much energy they've spent through exercising or just normal things. And so again, for them, it's not about, they're not trying to lose weight. They're not necessarily afraid of becoming fat. They just kind of don't realize, how malnourished they are. So sometimes they need quite a bit of convincing that, no, you actually are malnourished and you need to stay on top of this. It might be that they're a teacher or something like that, and they say, Meredith, literally, I have no time in the day to have snacks. I have like barely a 20-minute lunch break, and that's if I don't have, some crisis going on. And so they may, so that would kind of fall into that category. Someone who just, it's necessarily neither, but just they have behaviors that interfere with getting more nourished. The next one, body image disturbance or undue influence of body weight and shape on self-evaluation, or a persistent lack of recognition of seriousness of low body weight, which kind of goes back to the one before. But body image disturbance, this can be a little bit of a hard one, because, probably every single one of us in here has had days where we don't really care for our body and what it looks like or what we look like in these jeans or whatever, that's really normal. This is more someone who, it's persistent. It becomes very obsessive. They may literally try on, 10 pairs of jeans or 10 outfits or whatever it is in the morning before they even go to work or go to school. So, and even then, and then they obsess about it all day long. They may restrict all day long because of how they felt in that first pair of jeans that they tried on. They have really significant thoughts throughout the day, just indicating very poor self-esteem, very low self-worth, like, oh, no one's going to want to talk to me today, that kind of thing. And that's typically a little bit out of the norm, actually quite a bit out of the norm from the average. You wake up in the morning and you're like, oh, not my greatest day here, but you move on with your day. So it looks a little bit more like that, where there's quite a bit more obsessiveness. And also, I mean, let's be honest, like, our society and culture certainly doesn't make that any better with all the messages that we are sent through the dieting and fitness industry. And so sometimes it gets reinforced so much throughout the day. And then the last part is restricting type and binge eating or purging type. So you can be anorexia, it's like AN-R or AN- I don't know if they do B or BP. Anyway, it's so you can be you can have anorexia nervosa, and essentially your main behavior is simply restricting your energy input. If you're anorexia nervosa, binge eating / purging type, and this is binge eating or purging, okay? So if you have someone with anorexia who only binges but does not purge, she would still fall under this category, and vice versa. Someone who doesn't really binge, maybe they eat normal amounts, but they purge, that would fall. This is kind of either or. It could be both as well. So those are your two different types, and that's why there's no one who has anorexia and bulimia at the same time. Yes?
I just wanted to ask a quick question before we move to the next slide.
Yeah.
About the persistent behavior that interferes with weight gain. And you use the example of a teacher. And so, does that mean that you have persistent behavior that interferes with weight gain because of a fear of gaining weight, or just because they don't make time to eat, they therefore have anorexia? Or like, what makes that anorexia?
Right. It could be either or both of those. Absolutely. I mean, it very much could be, fear of gaining weight and they kind of, sabotage in that sense. Or again, it kind of goes back to the someone with anorexia who kind of falls a little bit more again, and the best word I can come up with is oblivious category, where they just don't necessarily recognize the seriousness of it. So to them, being able to say, well, I don't have time during the day for snacks, or I just, my dog needs walked. I have a really big dog, and he just needs, a good 3 mile walk every single evening. It's that for them, it's not about becoming fat necessarily as much as it is, hey, you are really underweight and you're really malnourished here, and your heart rate is this low, and you are, might be canceling social events or whatever in order to walk this dog or whatever. So it's more that, and so that still falls under anorexia nervosa. That one is a little bit less common. I more so just wanted to point it out that this can look like so many different things, but more common is going to be the ones who are intense fear of gaining weight or becoming fat. Yeah. Does that answer your question?
Yeah, no,
Okay.
It was just because I've never heard that before.
Yeah.
Before, so I was just curious about more what that looks like.
Yeah,
Thank
yeah,
you.
absolutely.
Well,
Yeah.
I will say so, and this is a question, I guess, too. But I have someone I'm thinking of in particular who has health issues, and so when people, I feel like this happens frequently, where people will get a diagnosis or doctors will recommend, you have high cholesterol, you need to change your diet to this, and then there becomes this like obsessive, I'm following, I'm doing exactly what the doctor said only, and you see this weight loss that becomes problematic, and having to tell, but that's what kind of reminds me of this oblivious, where sometimes they'll say, but I'm doing exactly what the doctor said. Like, there wasn't necessarily the intent of, I'm fat, I need to lose weight, or I can't gain weight.
Right.
It was more just, I'm following these orders, and this is my schedule, and I'm doing what I'm supposed to do.
Absolutely.
But not being able to recognize that it's gotten unhealthy.
Absolutely. And that is such like the perfect picture of how very black and white a lot of these individuals can be. You hear something like a doctor, say, oh, you have high cholesterol, you really need to lose some weight, Probably what that doctor really meant was maybe you can make a few lifestyle adjustments here and there, exercise a little more, get in a little bit other or more nutrients in this way, but someone with an eating disorder will hear that, and just, again, very black and white. Okay, I got to do this, and that's where something like that might be a little bit more later in life, where you see eating disorders really kind of develop much later on. We're really seeing that more and more in the last probably 10 to 20 years of research. Eating disorders, unfortunately, are starting younger, in very young children, and much older, and some women. And sorry, I speak more about women. I don't really treat a lot of men, and so my experience is more treating women, but men can absolutely have anorexia as well. But sometimes women in their 60s maybe develop symptoms for the first time. So yeah. Any other questions about this slide, or can just move on?
Can you speak just a second about what you mean by purging?
Oh, yes, sorry. Yes, okay, purging, we typically think of purging as self-induced vomiting. That's certainly the most common type of purging. I kind of think of purging as like essentially something that comes out of your body, okay? So it's self-induced vomiting. It might be using laxatives. It might be using diuretics. Those would be the most common ways to purge. I'm trying to think if there's another common. Yeah, well, that would be, so that's where I know that's where it gets sticky, because with bulimia, you can have purging or non-purging, and it's basically compensatory behaviors.
Like running?
That would be non-purging, because it's compensatory. Yeah, right. That would be non-purging. So purging, think of it as, there's some kind of fluid or something that's going to come out of your body, Yeah, okay, but let's move on to bulimia, because that kind of covers a lot more of that. So with bulimia, this is, I could say so much about this. I will say this: when I get a client with bulimia, I get a little bit excited, not because they're struggling, but simply because this has the higher rates of success with treatment, particularly with cognitive behavioral therapy. So for the most part, you get someone with bulimia, they're going to respond pretty well to CBT. Anorexia really could go either way, and research, it kind of tells us that. So So with bulimia, I think one of the reasons it's easier to treat is because most of the time someone with bulimia does not need to do weight restoration. So they're already going to be a pretty normal or average weight, maybe slightly above. And I think, and so therefore I think that a lot of times bulimia is far less egocentric than anorexia because the behaviors are a lot more disturbing to that person, particularly binge eating is very disturbing to that person. So they typically come in more motivated and ready for treatment and more willingness to kind of, do all the stuff that you're about to ask them to do. Not saying it's just easy. I'm just saying compared to really anorexia, it tends to be easier. So bulimia nervosa, and really the word bulimia refers to binge eating. So have bulimia nervosa, you have to have binge eating. I think that they do, it's 1 time a week for 3 months. I think our DSM-4 was 2 times a week for at least 3 months. So they kind of decrease the frequency of behaviors. So binge eating and just kind of there's a little bit of subjectivity to binge eating. I'll get, again, someone with maybe anorexia, binge purge type who essentially she says, I ate a hamburger. I mean, I totally binged last night, Okay, that is not a binge, To that person, it's a binge, but that's not actually a binge. But binges can range from, like maybe just for example, going through the drive-thru at Wendy's and getting, 2 burgers, 1 baked potato, 2 large fries, and that kind of thing, to, we're talking like 10,000, 20,000 calories in one sitting, going to the grocery store and just loading up an entire cart. Maybe it looks like you're about to have a party at your house, but it's really all for you and you consume all of that. So there's a little bit of subjectivity there, but essentially it's an amount of food definitely larger than normal in a discrete period of time and a sense of lack of control over eating during this episode. Yeah.
Well, with regard to sense of lack of control, does that mean that the person is aware of what they're eating, but they can't help themselves, or they're just not realizing how much intake?
Yeah, again, that one's a little bit subjective. A lot of times I'll get that some people describe it as a little bit more of kind of like an out-of-body experience, Some people describe it as more of like they're aware, but it's kind of like this frenzy. A lot of people just describe it simply as once I start, I can't stop. So it's not necessarily this, I kind of think about Tasmanian devil around the room. It's not that. It's just that it's like they get it in their head and it's like once this idea there is like a point of no return and you're going to keep eating whatever it is. So again, a little subjectivity with that one. It just kind of depends on the person. So that would essentially be binge eating. So there's binge eating with bulimia nervosa and then some kind of compensatory behavior. And that's where it can be purging or non-purging. So the purging, like we were talking about, is the self-induced vomiting laxatives. Non-purging is the fasting and excessive exercise, like you were talking about. Fasting, excessive exercise, those would be the main ones as far as compensatory behaviors. Essentially, some kind of behavior in order to prevent weight gain from the binge. So like I said, self-induced vomiting is going to be your most common one. This is where it gets a little bit tricky because every now and then I'll have someone come in saying that they have binge eating disorder, and I actually end up diagnosing them with bulimia because typically it's the ones who they don't realize that fasting or extreme dieting, they don't realize that's actually a compensatory behavior so that falls under bulimia nervosa, not binge eating disorder. I have found that those are kind of hard to treat, because they don't look at it that way. And they are ones who, if they have this self-identity, I have binge eating disorder, they are ones who really desperately want to lose weight, and they do not buy it that you are not really on board with that, at least in that sense. So that can be a little bit tricky. But remember, I mean, binge eating plus compensatory behaviors equals bulimia.
So just to be clear, somebody can have bulimia but not purge.
Correct.
Right. It doesn't have to include vomiting. And I think
Exactly.
that's something like society for the most part, and that's probably why people say, oh, I have somebody who has anorexia and bulimia. It's probably, if they have anyone who restricts and vomits, they assume.
Right.
I think people, for the most part, probably perceive that bulimia. I mean, how many of you guys before class thought that bulimia meant they were vomiting in some way or making themselves, right? So that's interesting.
Yeah, exactly. Yeah.
Okay, I promise not to do this for the rest of the time.
Sure.
This is also a question for Dr. McIntyre. So it sounds like anorexia would be a little bit more like OCPD, whereas this one's more like OCD, because like someone with bulimia is it's more treatable because they don't
They're more disturbed by it.
they're more disturbed by it,
Mhm.
whereas the person with anorexia wants to control it. They're not wanting to not control it.
Mhm.
Like, how would you compare? Like, why is anorexia not as successful with CBT?
Right. It's a good question. And I think that that's actually, kind of a fairly accurate way to look at that between those two diagnoses. I mean, I wish I had the answer to that. And I wish I had the answer of, what would work, I think a big part of it, again, is going back to this idea that anorexia nervosa is far more egocentric in the sense that it's you have these behaviors that seem to fit with your values and beliefs. Whereas bulimia nervosa, you have these behaviors, binging and purging or whatever, that do not fit in with your values and beliefs. Typically, someone with bulimia, I've come across a couple of exceptions, but for the most part, they are trying to control their weight. They typically start their day off saying, okay, it's a new day. I'm either skipping breakfast or I'm eating very minimally at breakfast, and they pack, this particular lunch to go to work. And maybe they skip lunch. They certainly skip snacks. By that afternoon, 2 o'clock, 3 o'clock, 4 o'clock, and those hunger pangs are hitting, and then and then you see the binging. It's like restricting in the morning, binge eating in the afternoon, evening, where was I going? Oh, so the binging and the purging, to an extent, they go against a person's values and belief, because really their values and beliefs are about, losing weight or looking a certain way, and we'll go deeper into that. Whereas anorexia, it's the behaviors fit more there. So then it's hard to convince someone of stopping those behaviors whenever they fit so well into their values and belief system. Does that make sense at all?
Yeah, absolutely.
Yeah, so that's where sometimes CBT with anorexia can be tricky, because you're trying to reevaluate behaviors and thoughts, and essentially trying to find a way to motivate this person and convince them of, changing their beliefs and behaviors will help them, and they're not buying it. They're not buying it at all.
As a dietitian, well, I'm sorry, like the anorexia, like carbs, like it's so known around that carbs are bad, and so I'm trying to work with them on the carbs are okay. So cognitively, they think I'm the issue.
Right.
Of what they're saying, and they're right, and so I don't get anywhere because
And I think the big thing, which you hit, Elizabeth, which I think is a great point, is eating disorders in general, but particularly anorexia nervosa, have this personality disorder flair, no matter what, right? That those of us that work in the field, you kind of know there's just this because there's this part of them that as mentioned, it's very ego dystonic, and I want to keep this. I don't see something wrong, right? There's not as much of where bulimia, there's an issue. Like, I know this isn't normal. Can you help me fix it, right? So they're going to be more on board to cognitively want to change and restructure their thoughts and change their behaviors. Where somebody with anorexia nervosa that comes in, they don't really see anything wrong with what, they think what they're doing is good for them in the sense, maybe not healthy, but this is who they are, and they don't really have the desire to change it. That's a lot different than someone who recognizes it as a problem, right? Like OCD, right? OCD, they know what they're doing doesn't make sense, it's illogical, but they feel like they have to, so they want help. Where OCPD, what they're doing makes sense, and that's who they are, and they don't particularly want to change that.
Right. Yeah, exactly.
So sorry.
Yeah.
But so when people with anorexia come and see you, they're usually then not there by choice. It's
Yeah, it's typically, well, if they're an adolescent, for sure, it's going to be their parents or some physician, or of course dietitian. I said, you need to see a therapist. So it's more like family members, close friends who are far more disturbed by it, and they kind of, find some way to force them in there. With adult women, it can definitely be a part of that. It can be, certainly a spouse, a partner, parents at that point. Sometimes it might be children. They might have an awareness of, these behaviors are not, I will say this, so the behaviors serve a function for them, but typically they'll recognize, I don't want my daughter to have the same things. So sometimes they will recognize that in another, in a child. And so sometimes it might be they will notice their daughter or their son doing something or saying something that mommy does, and it kind of bothers them. And so sometimes that will at least get them in the door a little bit, Other things, anorexia and bulimia, they're also very co-occurring with anxiety, depression, OCD, other things that are very disturbing. And so sometimes they might hit a point where it's like this depression, I can't deal with this anymore, or my anxiety has gotten so bad, that sometimes that will get them in the door. But typically it's going to be some kind of external force for the most part, external motivator. Yeah. Yeah. There was, let's see. I can't remember what it was. It left me. It'll come back to me later, I'm sure. Something about anorexia and bulimia. I don't remember what it was. So we did the behaviors, the same thing with self-evaluation. Oh, I know what it was. Sorry, just came to mind. They say if you look at something white, it something in your brain, you'll remember what you were forgetting. Anyway, so the other thing is you think about society and both of these types of disorders, you're typically going to have someone with very low self-esteem, right? And so you think about how society responds to these kinds of things. And for the most part, society hears about someone who's binging and purging and they're going, you do what? Like, you need to stop that. That's not good for you, But you hear about someone who's, oh, yes?
When you speak societal, I was just wondering if you've seen an uptick since like the pro-ana sites.
Have I seen it what?
Like an uptick.
Oh, an uptick. That's a good question. They're definitely there for sure. Actually in a form, yes, through social media. It may not be like a formal pro-ana site. Yeah, but for sure, pro-ana with like different following a particular person on Instagram. Like I've heard of that a lot. But I don't necessarily have statistics that it's gone up. I'm going to assume it has with technology and all of that. So,
can you explain
quick
what that is? It's the sites that people with eating disorder sometimes develop to encourage other people to stay involved in their eating disorder.
Like a blog or
Yeah, well, it gives them tips, tricks, diet, exercise. Pretty
Yeah.
much, this is how you have an eating disorder and
Right.
control
Yeah.
your image.
Yeah.
It's pretty scary.
Oh, it's very scary, absolutely. And it's very distorted. I mean, of course, you guys know that. Like, Carolyn Costin is a pretty big guru in the field of treating eating disorders, has written quite a few books. And at a conference a couple years ago, she was talking about one of her first books, I think. She just kind of wrote out this list of what she called the thin commandments. And she was really just trying to point out these are kind of the rules, that someone with an eating disorder will live by. And what ended up happening was someone took those thin commandments from her book and posted them on a pro-ana website as here's what to do. And of course she's like, that's not how that was intended. And I think she did get them to take it down, but it's just.
They've shut a lot of them down, but still it just seems they keep popping up.
Yeah, absolutely. So the other thing with anorexia is that, you come across someone who is eating very rigidly, maybe has lost some weight in the beginning, so kind of that person who, again, isn't so malnourished that it's so physically obvious, you look at someone like her and people are going to ask her, you look great. What have you been doing? Tell me your secret. I need to do that too. And so again, there's so much reinforcement for restrictive behaviors. And so with anorexia, again, low self-esteem, and you hear all that, it's very reinforcing in that sense. So I think that's another reason anorexia is more difficult to treat and bulimia is a little bit easier to treat. So, yeah. Okay, let me move on to binge eating disorder. This is really a new diagnosis. It was in kind of the back of the DSM-4 as like possibility, so we kind of had some idea of it. But typically with DSM-4, it was diagnosed as EDNOS, or eating disorder not otherwise specified. But now we have a whole new separate category for binge eating disorder in DSM-5, which is really nice because it gives so much more validation to these individuals who are really struggling. And side note, not to mention, it's going to make it a lot easier to research. It's going to make it, in theory, easier for insurance companies to cover for treatment and all of that. So it's really a very good thing that this has been included. So we've already talked about binge eating and what that looks like. For binge eating disorder, typically you're going to look at binge eating as, again, eating a large amount of food in a specified amount of time. Depending on the frequency and the intensity and severity, I might also diagnose someone who kind of essentially grazes all day long, where if you look at, let's take like a 16-hour time period, they're still eating far more food than kind of the average person, but it's not necessarily in a particularly discrete amount of time, like 2 hours, So again, if it's someone who does that every single day and it's been a long time and there's a lot of other stuff going on, I'll still diagnose binge eating. But typically it's going to be a little bit more, they're going through a drive-through and ordering, a lot of different things. So binge eating associated with 3 or more of the following. So eating more rapidly than normal. Again, they'll go through this food very fast. Eating until uncomfortably full. I mean, that's like anybody. Again, even if you're grazing all day, they'll do that. Eating large amounts of food when not feeling physically hungry. That happens frequently. And a lot of these individuals, whether it's anorexia, bulimia, or binge eating disorder, after, so many months or years of doing these behaviors, your body really loses its natural hunger and fullness signals. And so that's where a lot of times they don't realize that they're not physically hungry. They might be feeling emotionally hungry, but they mistake it for physical hunger. And that's something that they kind of learn about in treatment and start to get used to. We'll kind of talk about that later when I talk about self-monitoring. They will I would say almost everyone, I've had a couple of exceptions to this, almost everyone will eat very alone because of embarrassed of how much one is eating. And so there will be all sorts of kind of behaviors around eating it all in my car, before I have to head home for work. And then I'm going to go to this gas station so I can throw it away in this trash can before I head home so my husband doesn't see it, Or it might be, I've had individuals, they might binge at home, but they will go outside to the trash can, on the outside of the house and bury it underneath a couple of bags, as opposed to the trash can that's in the kitchen or whatever, kind of bury the evidence. I've heard of some adolescents and children will like kind of hide like candy bar packages, whatever, in the couch or in their bed or in their room, that kind of thing. So you'll typically see a lot of the hiding that goes on. And last one, feeling very disgusted with oneself, depressed, or very guilty afterward. I mean, almost every single time. Yeah. Binge eating, I've kind of found there's not as much research, I feel like, right now with binge eating disorder and CBT. I think partly because it's still a relatively new diagnosis, so again, it's a little bit harder to research without definitive criteria. I believe that there's this one CBT kind of self-help program that has shown to be somewhat effective. So I don't know much about that. Obviously, it's self-help, so it's not something that I would necessarily do in session, but I've heard that has a lot of promise. But otherwise, I have found binge eating to be, easier to treat than anorexia, but not quite as easy as bulimia. And my understanding from, I think, my own experience, and also I think research really, or I should say my own experience supports research, I think, is I think because, again, there's still, for the most part, one of two things: either a pretty big weight loss desire component of binge eating disorder. And so you will have a lot of these individuals come in and they just, throughout almost the entire course of treatment, still want to engage you in these kind of power struggle conversations of, but don't you think I should lose weight? I mean, come on, look at me, I mean, this is so bad for my joints and what's going to happen later. Like, Jill, come on, just tell me what I need to eat to lose weight, And I see that as like that I can think of 5 off the top of my head that just do that with some frequency. So you kind of have to learn to shut that down in a really compassionate way, which is a little bit hard to do. And then the other piece is that there is distress over the behavior of binge eating. However, these individuals almost go through much more of a grieving process of having to reduce the binge eating because food in particular has become such a comfort to them. Whereas someone with bulimia will still sometimes see food as the enemy a little bit. These individuals, they in some ways so badly want to stop binge eating, and yet they don't, because it's brought them so much comfort, and food has been kind of the only constant for a long time. So I see these individuals go through a little bit more of a grieving process. And so, treatment isn't necessarily as straightforward. The other thing is with really any evidence-based eating disorder treatment, you're not going to find anyone who puts these individuals on a weight loss plan. Like, that's not going to be part of treatment. And in fact, some research indicates that really even a reduction or elimination of binge eating may, in theory, at best, lead to like a 10 to 15% weight loss. So it's for some individuals, it is not what they would hope for, And so again, that can be really difficult for some people. And weight loss is not a part of cognitive behavioral therapy. That's not what it's about. It's about the behaviors. It's about the emotions. It's about coping skills and that kind of thing. So I think I have one more slide on binge eating. Okay, so marked distress regarding binge eating is present, occurs on average at least one time a week for 3 months, and it's not associated with recurrent inappropriate, so no compensatory behaviors in binge eating disorder, and also not occurring during the course of bulimia nervosa or anorexia. So that might be someone with anorexia who, binges once a week. But again, if she meets all the criteria for anorexia, she still has anorexia binge purge type, right? Someone with bulimia nervosa maybe has moments of binge eating without a compensatory behavior. But again, if they still have the binge eating with compensatory behaviors one time a week for 3 months, it's still going to fall under bulimia. Yeah. I think that's all my slides on eating disorder stuff. Any other? Oh, no, I have one more. Sorry, I'm looking at this. This gives you kind of a, what's the next slide coming up? I didn't know that. Okay. OSFED. This is kind of the new EDNOS. So this is what is other specified feeding or eating disorder. So this is basically, and this is where most individuals are going to be diagnosed. So most individuals who see you actually fall under this category. The percentage of individuals for anorexia, bulimia, and binge eating are going to be less than this one. And this is basically, I kind of look at this as someone who for sure has, it's above and beyond disordered eating. It's enough that I look at it causes some kind of, or at least one or many problems in the person's daily functioning, whether it's relationships, going to work, going to school, social life, anything like that, health for sure, if there's any kind of interruption or disturbance there. And then also sometimes, so like for atypical anorexia, this might be someone who, again, has all the components of anorexia nervosa, but perhaps she's not necessarily at a minimally expected weight or lower for her height and all of that. Maybe she's lost quite a bit of weight, but it's not quite that. You might, believe it or not, and Jill, correct me if I'm wrong, because you would see more of this, but for, and it's not a large percentage, but for a lot of individuals who have like gastric bypass or some of those kinds of things, who maybe, for example, start off at, what it should have to be like at least 300 pounds or something like that, right? Or it's BMI of 30. Okay. So like, let's say that they lose, 100 pounds from all of that, maybe 150 pounds. So they get down to like, let's just pick a number like 150 or whatever, well, they're not going to look, again, like your typical anorexic, but they would still potentially fall under that because of just the repercussions of having those procedures done and the obsessiveness with behaviors. They can pretty easily switch to a very restrictive disorder. So sometimes you might see that for atypical anorexia. This was a little bit better category from DSM-4. DSM-4 had amenorrhea as part of the criteria, which of course was not great for adolescents who had not started their period yet, premenarchal adolescents, or for men. So that's part of why they took it out of the criteria. But you may have, when I worked at Remuda, and I worked inpatient at Remuda, we had, I can remember this one patient we had there, 70% of her ideal body weight, I don't remember exactly what weight she was, but 70%, which is very low, and she had never once lost her period, which is really kind of amazing, And so with the old criteria, you technically wouldn't diagnose her as anorexia, you diagnose her as EDNOS. And so anyway, they kind of, adjusted some of that for DSM-5, but atypical anorexia nervosa might look like someone who, has all the criteria, just isn't necessarily at a significantly low weight. Bulimia nervosa, it might be, maybe it's not one time a week for 3 months, maybe it's a couple times a month, but they're still binging and purging. And for me, I would look at, is there still like all these safe foods or forbidden foods? Do they have problems in these other areas? Is there low self-esteem, perfectionism, all of those things, Same thing with binge eating disorder. Purging disorder would be more someone who probably eats pretty normally as far as portions and everything, but still purges, self-induces vomiting, or takes laxatives and that kind of thing. And I actually see that more frequently than some of the other ones as well. Okay, so I think that's all of the diagnostic ones, and I can tell I need to speed up. So let me just kind of go through this. So one of the reasons eating disorders can be quite a bit more complex to treat is because it's not just, needing to restore someone's relationship with food and weight. There are so many medical complications that can happen. Again, you can look like a really average weight and be incredibly malnourished with some of these things. So that's where it's always good to have them get a medical checkup and everything. Low heart rate, amenorrhea, which is losing your menstrual cycle for 3 months in a row. Low body temperature, lanugo, which is like really fine hair. Yeah, really fine hair. You'll typically see it like on the face or the arms, that kind of thing. And that's your body is a pretty amazing thing in that it really knows how to kind of compensate. Like our bodies know how to compensate for essentially periods of starvation. That's just like a biological thing that we have. And so a lower body temperature, growing fine hair over the body, lowering metabolism. That's your body's defense mechanism towards starvation, that it's trying to like slow things down so it keeps you alive longer. That's why it does that. Many GI issues. You're going to hear about constipation and diarrhea in most sessions that you have with someone. That's just kind of part of it at a minimum, and there's other stuff. Edema is edema is when you have like there's too much water, so it's like typically like in your lower legs and that kind of thing. Weight fluctuations, low bone density. So if I have anyone who's lost their period, really for 6 months to a year, definitely a year, but even sometimes 6 months, I really recommend they go get what's called a DEXA scan or a bone density scan. And typically, or hopefully, the physician recommends that too. The dietitian will, just to check for bone loss. So I've had 18-year-olds with osteopenia. You can have younger with osteoporosis. Jill and I had an adolescent one time who, I think hers was osteopenia, right? We had her when she was, we started seeing her when she was 11, and now she's this beautiful, vibrant, 16 or 17-year-old, however she is. And but with that, she, at such a young age, because right, you're still growing at that age, so there's a lot more permanent damage that can really happen when you're so malnourished and underweight at a young age. So she ended up with osteopenia, and she was a pretty big athlete, and I want to say she was having problems with just joints and that kind of thing, right? I think it got restored or it got better at some point. But anyway, so you see that? Yeah.
I'm sorry.
No, you're fine.
I was just wondering on the edema, is that because your body's trying to hold on to that water to compensate, like for your heart and everything?
I'm going to defer to Jill. I don't even know.
Oh, okay. It's usually protein, like lacto protein. Like protein holds on to water, so it's like third spacing, and where they end up kind of, and then the heart and how it's functioning. Okay, is well either. So yeah, it's kind of
Yeah.
those two things.
Okay.
Can you speak, and I know I'm not expecting, I know you're not an MD, so we can't give but what kind of heart rates do you see when you say low heart rate?
Oh, yeah. Yeah, typically you're going to look at in the 30s and 40s as a pretty low heart rate. Yeah. And I will tell you this, the frustrating thing from an outpatient perspective as a therapist treating eating disorders, and Jill, I'm sure you felt the same way from the dietitian side, you will have physicians and, really physicians tell the person or the family, oh, she's just an athlete. It's just because she just runs a lot. That's a good thing,
So I struggle with this a ton with my dad because, my dad was the person I was talking about earlier who has heart problems, was a pretty healthy weight, and the doctor said, you need to, only be eating this, and this, and so he took it to the extreme of like, that's the only thing I can eat, I can't have anything else, has lost a lot of weight, and he has, heart issues to begin with, but super low heart rate, and the doctors will say that continuously, well, he's a runner, and marathon runners, that's what their heart rate is, and this is good, and so he takes it as like, see how healthy I am, Liz?
Right.
Like, they're wrong. And it becomes this huge battle of,
exactly.
But it's not healthy anymore. And you don't recognize it. And, like, the
Right.
doctors can say, yeah, he could gain some weight, but really, everything looks good. And you're like, because they don't, like, saying that he truly is in that oblivious. Like, just does, it's not that he is worried about his weight. It's just that he's doing what the doctors told him to do for his heart. And so in his mind, like, I'm taking... What do you mean? Like, it's just this,
Oh, absolutely. Yeah. I have a good doctor if you want a recommendation. So.
Well, Dr. Tyson is
Dr.
one that
Tyson,
we work a lot with.
Yeah.
He's talked to me about the research shows that usually, like marathon runners won't go below 50.
Yeah.
Like a resting won't go below 50 or
Okay.
something.
Okay. Yeah, interesting.
I can't remember what he said.
Yeah, yeah, yeah. And that's what's hard. Again, you go to the fact that, when you have anorexia nervosa and again, egosyntonic, and you have a doctor saying, your heart rate's fine, don't worry about it, and you have your therapist and dietitian and, whatever, maybe psychiatrist going like, no, this is a problem, guess who they kind of side with? And then all of a sudden they have a professional opinion and it's like, I just want to like pull out your hair sometimes. And that's where I think, and Jill, we kind of get to the point where it's like, if you want us to work with you, you have to work with someone who knows eating disorders. Unfortunately, as far as physicians and the medical care, there's not that many in Houston, but there's a couple of really wonderful ones. So anyway, so weakened immune system tend to get sick quite a bit. Vitamin deficiency, I feel like I almost always see vitamin D is low. Cognitive deficits, sometimes you'll do like an intake and they're just very foggy. That's like the best way to describe it. Just very foggy, maybe take a little bit of time to respond. You're kind of wondering like, did they hear what I said or understood what I said? Excuse me, again, that one I don't see as common. That would be for like pretty malnourished. And then it's amazing once I start putting on weight and then you're like, you feel like you're seeing a whole new person, like, oh, like you're kind of funny and, whatever. So the psychological and social. So again, we talked, they're very comorbid with depression, anxiety, sometimes substance abuse, OCD, can contribute to unhealthy or unhappy relationships with others. This often leads to increased isolation and withdrawal. So again, it's not just food and weight. You're starting to get into all of this stuff as well. So pretty complicated, or it can be pretty complicated. Okay.
So we
Yeah.
just learned about OCD in more depth last week.
Yeah.
And with anorexia and kind of the OCD, I just tended can you talk about that more?
Oh, absolutely. And that's I'm glad you brought that up because that's another kind of pet peeve I have. If some of the OCD symptoms with anorexia, so typically that's going to be a lot of obsessiveness around like calorie counting, weight. They might weigh themselves 7-10 times a day. So for example, it might, if we're looking at it as obsessions and compulsions. So obsessions increase anxiety, compulsions decrease anxiety, right? Is that kind of around what you guys were talking? Okay. All right. So it might be I step on the scale. I look at the number. I'm like, oh my gosh, I gained 0.2 pounds, like how could this be, I'm going to go run 5 miles and I'm going to skip breakfast, so that's how you look at that. That would be essentially a flavor of an obsession and a compulsion, right? However, if those are really kind of the only behaviors going on that look like obsessions and compulsions, essentially if the obsessions and compulsions are around the fear of getting fat or the fear that I am fat or whatever, you do not diagnose OCD. OCD is diagnosed apart from anorexia nervosa. And so there are plenty of individuals with anorexia who also have some OCD symptoms, around contamination and checking and that kind of thing, but it's going to be very separate from the behaviors around food and weight and body image and all of that.
The main place that we see patients come to us, with an OCD diagnosis that also is an eating disorder diagnosis when they probably shouldn't have an eating disorder diagnosis is when it's typically around contamination or fear of vomiting. So we have a lot of individuals, it's a really big OCD fear, right, is that if I vomit, the germs that are in it, and so they start restricting. And so if they're not restricting because of fear of weight gain, it's much different, right? We're going to look at OCD. So I'll give you an example. If we also, we had a patient, there was a patient at Menninger who both eating disorder and OCD, and definitely had some eating disorder tendencies. However, when you really understood why she was restricting, it was because the fear of germs that were going in her mouth, and as she would eat, she would have to spit all the time and try to get these germs out and wipe her mouth a certain way. And so the restricting was more OCD based, right? Of that fear of germs than I don't want to be fat. The fear of I don't want to be fat wasn't there as much. But they can have both. There's no doubt. There's high comorbidities. But when you're going to see OCD and treat it as OCD is when these rituals are around something other than fear of gaining weight. If it's around the fear of gaining weight or around that, that's when we're looking more at eating disorder.
Yes, exactly. Yeah.
So I had one guy that was just obsessed about kosher. Everything had to be kosher. He was at the Houston OCD. And
Yeah.
I'm he didn't present, he wanted to be, leaner, but he was just losing a ton of weight because of that. So
Right,
is that
and
similar?
probably OCD, right?
Okay.
And so we see that particularly a lot when you look at Judaism, right? There are OCD type of rituals. I just did a
Right, I
training
guess
at
that's
Ben
spiritual.
Taub on Monday for OCD, and we were talking about this with a guy there who was saying, in Jewish culture, it is normal to keep your meat separate than your poultry. But it's different when it's a normal religious behavior versus your OCD is interfering to the point where all your food in the fridge is contaminated and this touched this, and when you put it up, you bought it at the same trip or whatever it might be, right? So, but yes, OCD versus eating disorder, and that's the main difference is what is the fear. Remember, we talked about this when we talked about OCD last week, is it's important to explore what's that fear driving it. Is the fear gaining weight? Then we're going to lean more towards, right, eating disorder. If the fear is contamination or vomiting or something of that sort, right? We see lots of kids restricting eating and losing a lot of weight, and the parents say it's an eating disorder, and what we find out is no, they're only eating certain food that's packaged because they're looking at expiration dates and they're afraid that they're going to vomit or whatever that fear is, where that's OCD.
Right, exactly. Yeah, those are great examples. Yeah. If it looks, again, if it's, or if it's eating disorder with OCD-ish kinds of symptoms, that's not OCD. Again, it's like the calorie counting, the excessive weighing. It could also be, and I'm going to talk about self-monitoring in a little bit, but this is where with some of the anorexia, I mean, I typically am like, if they don't already have a dietitian, I typically don't really ask them to do self-monitoring, or I'll ask them to do a really modified self-monitoring, because they can end up getting very obsessive about their meal plan. And like, it's like, it's got to be perfect. And here's what it looks like, and then they can go obsessive the opposite way, where it's like, well, that's great, you're getting everything you're supposed to be, but recovery is also about psychological flexibility and not being so black and white. And it might mean sometimes eating over your meal plan, and that's okay too. So it just essentially looks very obsessive in that sense. But I also have a client who has OCD, or I have several, but one in particular who has OCD apart from her eating disorder. And so she has kind of eating disorder stuff, and then she has OCD around, I think, one of the more current ones that she's facing is she will not drive on the freeway. So we really are only like maybe 25 minutes apart, and she will take like at least an hour to 2 hours to get there using all the back roads, because she's afraid that she will hurt someone on the freeway. She also has one with her kids getting out of the car. She has this obsession or this fear that their backpack is going to get caught in the car or the door, and she's going to take off, and then she's going to be dragging her kid, and so she has certain things around that she won't do, or she'll check many times before she, pulls out or whatever. So kind of some things like that. So sometimes it looks very, very separate, yeah, but again, looking at essentially what's the function of the fear that's going on is going to be kind of that defining criteria there. So I put on here the function. Wait, do I do from current slide?
Yes.
Talking a little too much, sorry. Okay. I put the function of an eating disorder because to me this is really important to go over with a client. Also, I added emotion regulation. I cannot even believe I forgot to put that on there because that's probably the main one. But emotion regulation can be a huge function of an eating disorder. And I like to do this because on the one hand, I find that for clinicians, again, eating disorders can be difficult to treat. And it can require a lot of energy. I find that, understanding it from this perspective really kind of increases compassion and empathy and gets you out of those power struggle conversations and can kind of meet someone where they are at that moment. And also, for clients who are quite a bit more disturbed by their behaviors, I think that this helps them understand, hey, this is not about the food. This is absolutely about something else. I always tell clients, all behaviors serve a purpose. It may be that the behavior is an unhealthy coping mechanism or whatever, but it is serving a purpose for you. And my favorite definition of an eating disorder, and I wish I knew who to attribute it to, but I read it in a book somewhere. The author said, an eating disorder is an irrational and unhealthy means of meeting rational and healthy needs. And I always really like that because it's like you have some very rational and healthy needs you are trying to get met in your life, and you're doing it in ways that are ineffective or maybe long-term ineffective, I should say. So let's figure out what those needs are and go from there, I wanted to read you guys something really quick. There's this our clinician and author named Dr. Anita Johnston, and she wrote this book called Eating in the Light of the Moon, which I think is actually a little bit more geared toward emotional eaters and that kind of thing. And she's a I don't know if she would really like CBT. She basically speaks in metaphors, and that's essentially what her therapy is. I mean, it's a very high-level skill, so wonderful. And she has this really famous metaphor when it comes to, I think, a function of an eating disorder. I wanted to read it to you guys really fast. Imagine yourself standing in the rain on the bank of a raging river. Suddenly, the water-swollen bank gives way. You fall in and find yourself being tossed around in the rapids. Your efforts to keep afloat are futile and you are drowning. By chance, along comes a huge log and you grab it and hold on tight. The log keeps your head above water and saves your life. Clinging to the log, you are swept downstream and eventually come to a place where the water is calm. There, in the distance, you see the riverbank and attempt to swim to shore. You are unable to do so because you're still clinging to the huge log with one arm as you stroke with the other. How ironic. The very thing that saved your life is now getting in the way of you getting where you want to go. This is not unlike the position many people find themselves in when they first become aware of their disordered eating. They feel foolish at best, humiliated at worst, that they are unable to stop a behavior that is interfering with their desire to get where they want to go in life. In the face of their shame, they quickly forget the role their disordered eating played in their survival, how it helped them keep their heads above water through some very rough times by giving them a way to deal with their conflicts, feelings, and difficult situations. They immediately assume that there is something wrong with them. There are people on the shore who see you struggle and yell, "Let go of the log!" But you are unable to do so because you have no confidence in your ability to make it to shore. Perhaps simply letting go of the log may not be the best course of action to take. What would happen if you let go of the log, began to swim to shore, and got halfway there only to find you didn't have the strength to make it all the way? This means that you wouldn't be able to make it back to the log either. And so, very slowly and carefully, you let go of the log and practice floating. When you start to sink, you grab back on. Then you let go of the log and practice treading water, and when you get tired, hold on once again. After a while, you practice swimming around the log once, twice, 10 times, 100 times, until you gain the strength and confidence you need to swim to shore. Only then do you completely let go of the log. Recovery from disordered eating begins with the understanding that the disordered eating behavior served you when your goal was survival. This understanding is then followed by the development of new skills that will enable you not to simply survive, but to get what you want out of life, to thrive. So, and actually, I don't know if she's a fan of CBT or not, but I think that fits really nicely into CBT, right? Because CBT can be, it's such a progression that you're going towards. And I just like that because I think in some ways it's really validating that, hey, you're not crazy. Like, having the eating disorder has really served a huge purpose in your life, and we want to get you to the point where you no longer need it. You use other things to get you what you need and going above and beyond that with life. So sometimes reading this to a client can be a slam dunk for them, and sometimes it's, enlightening in the moment and then they forget it the next week they see you. So anyway, so, okay, let me move into some CBT kinds of stuff. So I'm assuming you guys kind of know the basic components of CBT, right? The CBT triangle. And so a lot of times in my first couple of sessions, I'll draw this on a piece of paper and just kind of explain to a client how all of these different components interact with each other and are related. I might differ a little bit with this. I'm not sure what other CBT clinicians do or what necessarily a CBT manual would say, but I will often tell clients that our therapy is going to focus on behavior and thought change. I try and make a point to say that I'm not looking to change emotions necessarily. Emotions serve a function. They are very important to recognize and validate. What we hope is that by changing some thoughts and some behaviors, it reduces the intensity or the disturbance of certain emotions to where they can at least become more tolerable and manageable. Yeah.
Can I use like a DBT approach?
Yeah, you know what? That's probably a lot where that comes from a little bit. When I worked at Remuda, we did CBT and DBT, so that's probably where I got it. Absolutely. But so that might differ a little bit than what you guys have been told. So CBT techniques with eating disorders, these are typically the ones that I use. And these are really kind of your core techniques. So again, there might be other CBT techniques that are out there that are used. These are kind of the basic ones. So I want to kind of go through each one and tell you, I want to kind of tell you from like CBT manual-based treatment, what that may look like, and then I might try and give you a flair for kind of what I do. Because essentially what I have found on an outpatient basis is that a lot of people they don't like homework, and some of it's not that they don't like it as much as just life happens when you're on an outpatient basis, and they're not going to do it every week. And so I think that I have found that I try to simplify a lot more of my worksheets, and I have some worksheets in y'all's packet that, again, they're going to be very simplified compared to some of the stuff you guys have already seen, because I've just kind of found over the years that they're not going to do something super complicated for the most part. I've had a few, but amazingly, the few that do that, those tend to be the ones that are very obsessive and perfectionistic, and you kind of want them to get away from that. So anyway, but self-monitoring is really
That's
kind
why our OCD people always do their homework.
of, yeah, exactly. So in self-monitoring, the way that this looks for the most part with bulimia nervosa anyway is and this should be the first kind of handout there that looks like this. And I will typically assign this to them with bulimia in the first session or two, particularly if they don't have a dietitian. If they already have a dietitian, then I'm kind of like, what's your dietitian having you do? And then I just kind of go from there. But with self-monitoring, I essentially want them to become just aware of their patterns. And I tell them we're not necessarily looking for change at this point. We just kind of want to get a picture for what's going on. There's no judgment with anything. A lot of them will struggle with this. Binge eating disorder will struggle with this because they are so ashamed of their behaviors. They do not even want to write down when they binge or anything, So self-monitoring can be a little bit difficult, but I find it really important as a clinician for seeing the patterns that are going on, and that's typically why I like to assign it. I had someone recently she's a lot more of a compulsive eater, emotional eater, not quite binge eating disorder. And when I did this with her, I just kind of asked her, what was it like for you? What did you notice? And any patterns emerged for you? And the first thing she said was, she's like, I did not realize how much my anxiety played a role in all of this. I think she noticed on her self-monitoring how much anxiety was a part of the times when she was using a behavior. And she said, I think my anxiety has been, at this level for so long, I thought that was my baseline, when in reality, my baseline's down here, and I've just gotten used to this one. So that's something that she noticed on her self-monitoring. Manual-based stage 1 for bulimia nervosa, and I had to write this down because, again, I don't do all of this. They actually have the client weighing themselves weekly. I don't know that you will ever see this with a therapist or dietitian who knows what they're talking about with eating disorders. I could be wrong. Maybe there are some people who do. But as a therapist, I do not weigh clients. And in the manual base, they want the therapist to weigh the client. And I have a problem with that. I think it can get in the way of your therapeutic rapport. Also, I am trained as a therapist, not as a doctor or a dietitian, so I don't know why I'm the one monitoring weights. I don't know what's right for someone. That's not my training, but that's in the manual. And also, I do not like clients seeing the number for a long period of time. They are so disturbed by it. I cannot imagine someone doing this in week 1. And, the purpose of it in the manual is for clients to begin to see that you are not going to get fat, gain tons and tons of weight, whatever, from eating regularly. That's the point of it, that you're essentially building evidence for your body knows what to do with food. That's the purpose of it. But I don't do that. Therapists in stage 1 will also just establish regular eating patterns. So at that point, they're not telling the client what to eat or necessarily or definitely not how much to eat. They just say you need to be eating regularly. So typically 3 meals and 1 to 3 snacks a day. Again, I'll do that if someone has come in without a dietitian, but once they start seeing that dietitian, I'm kind of off all of that. And then they'll do psychoeducation on eating disorders, on the ramifications of eating disorder behaviors, some of the medical aspects and what could happen and all that, just psychoeducation, establishing regular sessions. They will teach the client in stage 1 to learn how to surf urges for binging and purging, so coming up with distraction techniques, alternate behaviors, that kind of thing. Even if it's just surf that urge for 30 minutes. And if you still want to binge or purge after that, then okay, but just give me that 30 minutes. So doing some of that. They have in there, and again, I do some of this, not all of this, but they call it self-control strategies. I don't really use that term, but they will say in the beginning, someone may want to limit binge foods that are in the house, not eating in cars, not eating on the go, identifying high-risk situations, and then, kind of plan behaviors to avoid a binge. So all of that will be in stage 1 of bulimia nervosa. With anorexia nervosa, again, because of the lack of motivation being very different and all of that, a therapist will take quite a bit of more directive role. With bulimia, you're kind of more, there's kind of this really nice balance of empathy and firmness with your recommendations and all that. With anorexia, you're gonna want to be a little bit more directive. Um, and leading by example. And that is one thing I found, that I might see someone for a year or two and they still aren't really buying into what I'm saying after a year or two, but they will start to talk about, oh, this lady at work started talking about this, and I remember when you told me this 3 months ago, and I said that, you know. So she may not be living whatever it was I told her, but she will start to like say that to people. So leading by example can be very important as a therapist. Your own beliefs and attitudes toward food, weight, appearance, and all that really will rub off on anyone that you see. They will pick up on that. That's the other thing. These women with eating disorders are two things, every single one of them, incredibly smart and incredibly sensitive. And I think that both of those things that go on, they are very perceptive to whatever's going on around them. And they will pick up on your stuff. They will know when you're having a bad day.
Question.
Yes.
Have you seen an increase, or what's it been like for you just in the past 5 to 10 years in the field, of the differences between kind of this like organic and this push for eating healthy and eating natural, but having a balance, and I guess kind of understanding like when is that normal societal push versus eating disorder?
Yes, that's huge. And actually, there's kind of a cultural term called orthorexia. Have you guys heard that before? Not a diagnosis. You would still diagnose anorexia or bulimia or OSFED, but that's kind of the casual term we would say is orthorexia, and kind of this obsessiveness with, really the health aspect. So typically whole foods or eating clean or whatever it is, Yes, I mean, that, and there has been a huge increase in that, it feels like. And again, that is so difficult because you can get someone, restored to the weight that they need to be and all that, but they are just digging in their heels with, trying different foods and getting in a good variety and, eating fast food and going over here and just everything in moderation. And so, but to them, they're like, I'm at a healthy weight. I'm not making myself throw up anymore. Like, what else do you want from me? But again, recovery is about so much more about flexibility, because the thing I look at with that is, and at what point is it normal? So I have the mom of one of my clients who is definitely into all that stuff, but, me and the dietitian, Jeff, did an assessment with her himself. And, she kind of provides all that at home, but she can totally go out to eat with everyone and eat a burger and a milkshake, and so she does not allow any of those things to get in the way of like, her functioning, whether it's flexibility with, oh, these people invited us out to dinner, let's go out with them, or this birthday party, and whatever. And I think that's a lot more of the normal kind of thing. Someone, more eating disordered and all that, there's no flexibility there. They will not go to that birthday party, or they will be the one to bring, their own salad dressing to the restaurant or whatever. So yeah, that's a great question. So with anorexia, you can do, the manual talks about either gradually introducing self-monitoring or meal planning. What I typically do is the dietitian will do a meal plan. I don't actually get a copy of it, but I essentially follow up on questions. How are you doing on your meal plan? What percentage are you completing each day? Tell me what's easier than you thought, what's more difficult than you thought, what are some of the obstacles, that kind of thing. So,
which is helpful for me, because sometimes we'll communicate, and sometimes they'll say something to her, not to me.
Right.
So
Yeah.
it's good to know that you're even asking those things.
Right. Yeah, absolutely. Yeah, there's a little bit of good cop, bad cop with therapist dietitian. It's kind of hard. Mostly it's the dietitian who's the bad cop, unfortunately. Sometimes it's the therapist, but sometimes they'll say something a little bit more to the therapist. But and what I was going to say about self-monitoring in particular, so I have this paper for you guys. I typically don't give this paper out because there are a couple of really cool eating disorder recovery apps that someone can just download on their phone. I think you probably use Recovery Record a lot. Recovery Record is probably the most popular one. I don't use it because they started charging clinicians to get the data, and I don't have enough clients who really, first of all, I'm not the dietitian. Secondly, I don't have enough clients who do it regularly enough for me to justify paying for it. There's this other one called Rise Up, and I will do that one for clients who are just getting started in treatment or that kind of thing. And I really like Rise Up because they can still export their data to their therapist or dietitian, whomever. And I think it's pretty simple to use. Do you ever use Rise Up? Okay.
I've used the Recovery, they can still log on and send their data to you.
On recovery record. Do they still charge for it though?
Well, no, they can send it directly to you without charging.
Oh, recovery. Oh, I didn't know that. Okay. All right. Well, anyway, Rise Up is
And
anyway.
do either of those track calories?
No, I don't think so. Yeah.
Right, so that's the difference between, well, why don't we use MyFitnessPal or things like that. Right?
Oh, yeah. That's a great point. Absolutely. So that's self-monitoring. Just for the sake of time, let me speed up a little bit. I feel like I was worried about this. I just would have too much to tell. With stage 1 for anorexia nervosa, manual based, they don't weigh themselves. A therapist or dietitian or medical provider will weigh them. In stage 1, you may also want to show the causal model of eating disorders, and so maybe show someone it kind of starts out with low self-esteem, and then this kind of flows into extreme concerns about weight and shape, and that leads into extreme dieting, that leads into binging and purging, and so you kind of start helping your client develop this awareness of how all this has kind of started and the maintenance of the disorder and what that looks like. So again, a little bit more psychoeducation going on there. Obviously, in stage 1, I should have started with this. The therapeutic relationship is of utmost importance with anything. I remember in graduate school, they told us all the time in our theories class, no matter really what theory base you kind of adapt or whatever, the most important part that research continues to support is the counselor-client relationship, or the relationship that you have with them. So that, of course, is very important here as well. So basically, stage 1 is doing all of that, setting parameters, establishing kind of some guidelines and more the structure of what therapy looks like. In manual-based treatment, they have bulimia nervosa as about 20 weeks, so they're very specified sessions. I don't do that. And side note, 20 weeks sounds very, very short to me. I think eating disorder research more shows like 3 to 5 years. Anorexia nervosa, they say treatment more like 1 to 2 years. Again, that sounds pretty low to me. It's going to be 3 to 5, 5 to 7, something like that. Also, with anorexia in stage 1, there might be more interpersonal themes that are discussed, just because with bulimia nervosa, there's definitely some interpersonal issues that go on for sure, but someone with bulimia will still potentially go out to parties and go to their friends' homes and all that, but they will just kind of scope out the bathroom to purge or whatever, Someone with anorexia will just skip all that. They just won't go. Again, the isolation and withdrawal is more significant, so you'll want to address that in stage 1 as well. Stage 2 is more about, or let me see, do I do any of this in stage 1? I probably do more of the ABC stuff in stage 1. Stage 1. So that should be the next handout on there, where it has, I even did a couple of examples. Okay, what do you know? Activating event, and again, I kind of modified this. Real CBT might adjust this a little bit, but I have activating event, beliefs and or behaviors, and then consequences. I typically tell clients, think about consequences simply as the outcome. It doesn't necessarily have to be bad. We typically think of consequences as negative.
And these, just so you guys know, as far as what we're learning, this is often, like, ABCs are often done before a thought challenge. So if you remember, we looked at like a full thought challenge last week. It's important to do the ABCs prior, so that you they're starting to understand before you're really challenging them and you're really starting to do that full thought challenge. This is kind of that first step, right? And so the activating event is that same thing. What happened? If there was a camera in the room, that's the facts of what happened, not something made up. Instead, then your beliefs might be what are made up in the consequences.
Right.
Sorry to interrupt.
Oh, no, that's good. Yeah, and that's another reason it's better to do this more in stage 1, kind of in the beginning, before you get into cognitive restructuring and all of that and trying to change some of that. And also so they develop awareness. What are the beliefs that are going into all this? Because some of these behaviors are so habitual for them. If you've had someone who's done this for years or decades, they'll tell you, I don't know why I binge and purge. That's just kind of what I do, So this kind of helps them to pause and look at what are the different triggers and stressors in their lives or activating events. So I have a couple of examples there. I also included, what I do with my clients is I also try to get them to start learning, what are some beliefs and behaviors that you have that actually lead to more positive consequences. And I try to get them to either think about it or play around with it. I maybe don't do this in stage 1, but maybe later on. But that's the last one. So activating event was I ate 100% of my meal plan. Beliefs, this has been really difficult because I feel so bloated, but recovery is worth it. So that's the belief, right? And then behavior, I went out to a birthday dinner with friends. Consequences, I felt anxious about eating all the food. And again, with all of that, the anxiety will a lot of times increase, right? Because you don't have the behaviors that's kind of suppressing the anxiety. So the anxiety is going to come out a lot more usually. Mood typically gets better because, again, you're nourishing your body, you're nourishing your brain, so you tend to feel a little bit better mood-wise. So I like them to be very real and honest. I'm like, if increased anxiety is part of eating your meal plan, that's very real. That's okay. Anxious about eating all that food, but otherwise in a much better mood, and I actually pooped today. So I put that as a consequence because you'll hear that. They'll talk about that, and you talk about some of the physicality or the physical stuff that goes on with eating disorders, and it's important to acknowledge, yeah, when you eat, your body knows what to do with it. That's kind of how it functions. So hopefully that's okay. Okay, and then stage 2 is where you get more into, I'll introduce cognitive distortions, which is that page. That's just from the Feeling Good book by David Burns. I hope it's okay I copied it for you guys. I might get in trouble, I don't know. But I'm going to give him credit. That probably has a very comprehensive list of various cognitive distortions. Again, the all or nothing thinking is probably going to be the most significant one that you'll see. Definitely the should statements. Oh, I shouldn't eat this. I shouldn't have eaten that. I should look this certain way. And then the catastrophizing, overgeneralization, a lot of times the personalization are the ones that you'll see. And so in stage 2, you start to address more attitudes about food and weight and that kind of thing with bulimia. And so that's where when I start to do cognitive restructuring, you help them, again, with the psychoeducation, seeing a dietitian, you help them understand better about what the research really says as far as what your body needs and how much of it needs and what your body can handle, and then you start to introduce the cognitive restructuring where you're helping them with identifying what are your automatic thoughts, what distortions does that fall under, and then what's the evidence for and against and all that, and then how can you kind of reframe those thoughts. I kind of combine those last 3 into this last column. As you can see, I just did a very simplified version. So doing some of that more in stage 2. Also stage 2 with manual-based, for bulimia nervosa, they want to eliminate the dietary restraint. So that's where in manual-based, you're going to encourage the client to start incorporating more of their forbidden foods or maybe, settings that they won't eat in. I will not eat with this person. She is so skinny and she does not know what it feels like and I refuse to eat with her, So you might encourage them to start incorporating a little bit more of that in stage 2. Problem solving. Oh my gosh, yes, problem solving. This to me is like a really important part of your therapeutic work with a client. And sometimes I have to remind myself that they are in a place where they genuinely don't think of these different ideas. But so let's take the teacher example from earlier, Mary, I barely have 20 minutes to even get down my lunch, I don't have time in the mornings to, pack 3 snacks and whatever it is, you have to help them do some problem solving and come up with different scenarios. Okay. First of all, is there anyone in the house? Is there a roommate, a parent, a partner who can just pack your snacks for you? Can you keep a box of granola bars in your car or in your purse? Maybe not a box in your purse, but can you keep a granola bar in your purse at all times? Just doing different things like that. Can you, give your kiddos an assignment in the class that keeps them busy for like 10 minutes while you sit at your desk eating, string cheese, something like that, something pretty simple. And a dietitian really is helpful with whatever foods are easy to eat during that time, but you have to help them with a lot of problem solving because, again, very black and white thinking, like, oh, I forgot to bring my snack today, so I just can't do it. When in reality, maybe there's like a few vending machines in the building, or maybe you had an extra 30 minutes you didn't realize, or maybe there was a coworker who was like, hey, I'm going to Starbucks, do you want anything, So you really have to help them with that problem solving because they're going to be in this very concrete black and white world. So you'll do a lot of that in stage 2. In stage 2, you might also do a little bit of what I call exposure to body image avoidance, and that's where a lot of times individuals with eating disorders they will wear very baggy clothing, or they maybe haven't gotten in a bathing suit in years, so they refuse to have this really wonderful day at the beach that all their kids are going to or whatever. So you kind of start challenging them with a little bit of that, wearing a little bit more tailored clothing, and I really encourage them to go to, even if they don't buy it, go to higher end stores. Higher end stores are going to have better quality clothes, whereas if you go to what would it be like let me say this. I wear Old Navy clothes. Okay. I'm not saying that, but I am saying there's a difference in going to Old Navy and trying on a medium versus going to, like Nordstrom or, Banana Republic, I don't know, and trying on a medium. There's going to be a difference in the quality. There's going to be a difference in the sizing and the cut and all of that. Yeah.
But what about like vanity sizing, right? Because aren't you seeing a lot of that now?
Yeah, right. Like now a size, like someone was saying this the other day, a size 0 is really a size 6 of 30 years ago or whatever it is.
Well, not only that though, but like for example, I went to Ann Taylor the other day, and their sizes are so much bigger than what the number is.
Right.
So like they're making people believe that they're a smaller size.
Yeah.
When they're really not. So
Well, more expensive stores do that. Like
Right.
Nordstrom, if you go to Neiman's and you buy a dress suit from Neiman's, you might be like a 6 in a suit. If you go to Target, you might be at 12. Legitimately, it is
Yeah.
that it can be that big of a difference.
Yeah, exactly. No, and all that's very true. And I never try and sugarcoat any of that with clients. You know, if anything, I more talk about it's a number. What does it mean? You know, you can be a 6 here and a 12 here, and you know, if that's going to affect your mood that much that day from shopping at Nordstrom versus shopping at Target, like, okay, we need to talk. You know, so I typically have more conversations like cut out that tag if you need to. Go shopping with someone who will pick out a selection of sizes for you, and you go into the dressing room. Do not look at the tags, and you just try on clothes and you buy what feels good, and then you cut out the tags when you buy it, you know, if someone really needs to go through all that. But otherwise, with cognitive restructuring and all that, it's really a lot of, you know, do you want the fashion industry to essentially determine your self-worth and your, you know, your self-esteem and all of that, and to have a lot of those conversations. And again, you may have those conversations for 3 or 4 years before it sinks in, but you know, or maybe not that long, but you know, so yeah, absolutely. I mean, again, the fashion industry with a lot of that doesn't really help either way, you know. Yeah. And a lot of times with others, it's more, I get a lot of women like this who are, it's like they are a size 14 or 16 and they will say, I promised myself I would never get into plus sizes, you know? And it's like, and it you know, and again, they do that maybe like 10 years ago, they were in 8. I will never get into double digits, you know, and you will kind of see that line of thinking all throughout. And the idea of going into double digits or plus sizes or whatever it is just so disturbing to them. So you have to do a lot of, you know, really the cognitive restructuring, some of the ABC stuff with what's going on there and what has happened that's kind of led to those beliefs, you know. Yeah. Yeah. Stage 3 with both is basically you're doing relapse prevention, you're anticipating future difficulties, and just kind of preparing for what you'll do. I don't necessarily have a worksheet on this. It's just kind of what you would do in manual-based CBT. You might write out a maintenance plan, you know, what you're doing to maintain your recovery. You normalize setbacks. You know, sometimes it might be you have a random binge and purge, you know, every few months or once a year or something. And again, with the black and white thinking, if it's not if it's not gotten much better at that point, you really have to normalize, like, hey, that happens. Look at it as a learning opportunity, you know, instead of like, of course, any shaming or like, oh, you made so much progress. What happened? You know, that can be really shaming. So instead, like, tell me about what happened. What was going on for you? And what would you do differently next time? Like, okay, it was a slip. You know, let's move forward. Obviously, if it keeps happening and becoming a pattern, you need to address that. But so normalizing slips and setbacks and that kind of thing. With anorexia nervosa, and this is where, I don't know if you guys read in the article, and this will be the last thing I say. If you guys read in the article, CBT dash E, and then there's like EF and EB or whatever. So I will say I did not learn that in graduate school, so I don't know, you know, if there's someone who does that every single day, they might say something different. But my understanding is that CBT enhanced, the F is for the focused, and that's where you're doing more of the CBT for a group that's much more about the food and weight and all of that, and CBT enhanced B, which I think stands for broad or broadened or whatever, you're also doing all of these CBT techniques for self-esteem, perfectionism, sense of control, relationships, like that kind of thing. So so you could also easily do all of this for, I'm trying to think of I don't remember if my cognitive restructuring, if I did an example about relationships. I don't know if I think I kept it pretty, no, I didn't. I kept it food, but
I think that's a great point that you bring up, is I think a lot of us get stuck in this, you know, if we're doing CBT for OCD, then we are only doing things to, you know, we're only doing ERP and we're working on their OCD and that's it, right? And we talked about this in class 1, where a lot of you guys said, well, what happens if there are family issues they need to work through, and should they not get psychodynamic? It doesn't mean we can't use CBT with family issues, right? And I think that's a great point, is that there is CBT that's going to be focused for eating disorders, but they have comorbid or life issues or family stuff they haven't worked out. We can still use these CBT interventions, which we know are very effective for a lot of these other issues as well. And that's really what you should be doing as a CBT practitioner. Even if you specialize in OCD like I do, or you specialize in eating disorder like Meredith, it doesn't mean that's the only thing you're doing. And when it's something outside of OCD, I say, well, that's not my specialty, let me send you here. No, how do you use the same technique to navigate the needs that they need in the session?
Yeah, absolutely. Yeah, absolutely. And that's where CBT is just a big component of treatment. But again, going back to statistically speaking with anorexia and binge eating disorder in particular, yeah, like CBT is going to be one of those techniques that you use, but you may have a lot of others, kind of in your tool belt that you just kind of have to choose from, and what's more effective for someone else. So yeah, okay, I think I've left you guys maybe 5 minutes for questions or whatever. Is there anything else that's come to mind with all of this?
You said fasting earlier. Is there an amount of time that has to pass before it's considered fasting?
That's
Because
a good
if someone
question.
doesn't eat, say, for 3 hours, that's not considered fasting, right?
Right, I wouldn't imagine. That's a good question. I don't actually know if there's, kind of a clinical definition of fasting versus extreme restriction or something. Jill, do
It's
you?
usually like less than 1,200. Like if someone's 300 pounds and they're eating a 1,500 calorie diet, they're fasting.
Yeah,
I mean,
okay.
because their caloric needs are much different.
Uh-huh.
But a lot of times they're saying it's like less than 1,000 calories.
Less than 1,000. Oh, okay, yeah, good
And
question.
I would imagine there's been a big kind of increase for you guys with this, like, juicing, and all these new techniques of, now I'm going to do juicing cleanse for 3 days, and then what does that lead into, right? If I see a spike in weight loss, do people become obsessive, and then it becomes that I have to juice it once a week or whatever?
Right.
Talk a little bit about, if you can, just like any experiences you've had of kind of where these fads play into. Right.
Yeah, absolutely. Yeah, fads. I mean, gosh, something like that, eating clean, the paleo stuff, that's where, what's that?
Vegan, vegetarian.
Yes, exactly. All of those things. And that's where, and I feel like the more I'm in the field, I get a little bit more skilled at this. I would not have responded this way when I was first starting, but I think what you have to do is really go underneath that. Well, tell me about that. What led into your decision to start that? What do you like about it? What do you hope to gain from it? What's your understanding of the research behind the paleo diet or whatever? And just kind of really asking a lot of those questions. And then really if I know more about it, like I'll do psychoeducation on it. Well, did you know this? Did you know vegans can be incredibly malnourished and da 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 da? Or did you know Jill sent me this really great article on the paleo thing. Did you know that actually in the Paleolithic era they ate crickets, and and if they had come across a honeycomb, they would have totally binged on it, or whatever. That was just survival. But anyway, doing a little bit of psychoeducation, helping them, because odds are they probably read something on Facebook, thought that, yeah, I'm going to try that. That's healthy, but they actually haven't researched it. They don't know really anything about it. And also the whole clean eating, there are so many definitions of that. And, one article from another is like, I think you can't eat like oranges or orange juice when you're eating clean, and that's according to one article, it's like helping them, like, really, if you're going to do this, where is this coming from, and have you researched it, and what's this about,
And is it effective? So I have a friend who's paleo, and I know a lot of people that do diets that I'm just worried and unsure of why they're doing it. But I have one friend who is on the paleo diet, and she's very strict paleo, and at first it was like, oh my gosh, no one's about to eat with her. We can't, like, it was just this whole process. And as you got to know her, you learned more about her. Well, she has MS, and it has truly effectively helped her manage her MS for her. And, research or not, if it's working for her, that's great. And she is, and the reason I think off the bat I can tell you there's no eating disorder flare there is that when she travels and things like that, she'll say stuff like, I'm going to do my best, but whatever. Like, I'll eat when I'm with you guys, and, I'm not going to ruin a vacation because I need to stay strict to it. But she does notice if she eats sugar and certain things, she has more inflammatory issues. But then there's a lot of people I know where, like, I think of, I guess I have one of my questions would be, I'm thinking of a couple different cases, but an individual who would make comments of like, well, one of my goals is to gain weight. So do you guys hear that with eating disorder? Like, so but I don't really think the goal is to gain weight. I think that's just like, I say that because everybody tells me how thin I am, but the behaviors we see are like restriction, we see over-exercising, right? We see all these things that none of it adds up to the gaining weight, but then the comments are like, well, I'm trying, or that's really, I know I'm too thin, my goal is to gain weight.
What I see in that context a lot, and this is from more of my adolescents, and their parents will also support this, is, okay, well, I'll gain weight, but I want all of it to be muscle, you know? And so they will try to negotiate a lot with the dietitian on, well, what if I did this instead? What if I do muscle milk instead of Ensure, you know, whatever. And so that's what I see a lot. And again, it goes back to, you know, the body image and the undue influence on weight and shape and all that. And they do a lot of bargaining and negotiating exactly like that. Yeah, that's a great point.
What are some other questions you guys have?
Well, I really appreciate you guys letting me come. I love CBT and eating disorders, and so I was excited to come talk to you guys about that. I did put my email on the, oh wait, no I didn't. Well, okay, I put my website. I guess I didn't put my contact information. Well, okay, I put my website on there. If you have any other questions, please feel free to go there and just send me an email, or my phone number's on the website. Give me a call. I'm happy to answer any questions or anything that you guys have. And yeah, just thanks for letting me come. I appreciate it.
Thank you.
Yeah.
So I have one quick question. What about overeating? Would that be in the category of, I mean, what if somebody's not necessarily binging, but they just always are eating all the time
Yeah.
and overweight?
Right. Well, the overweight piece. Let me just grab this guy out of your way.
Don't full rush.
The overweight piece, I don't really worry about too much because, again, it could simply be someone's genetics that they are that weight and shape. It could be a side effect of a medication that they're on. So I don't really worry about the weight piece, really. What I would look at in that situation is what's the function of the overeating? You know, is it emotional? Is it, you know, not listening to hunger and fullness cues? Is it a coping skill? You know, I would look at the function of it. And if it's something that falls into that realm, then we would certainly address it. But if it's, you know, someone's overweight or whatever, and they like have really normal eating patterns or whatever, or maybe just occasionally overeat, that's called normal, you know? So, yeah.
Thank you.
Yeah, absolutely.
Thank you so much.
Oh, you're very
It's a little
welcome.
kinda
Oh my
quick for you to
gosh.
just put it in your purse.
Thank
Just
you
a
so
little quick
much.
note. We appreciate it. Thank you.
Thank
Do-
you.
Feel free to, like, we're not rushing you out.
Oh no.
Spend time going over the handouts and this, like all these wonderful documents that Meredith gave you. A little cue is that you guys can expect to do these during role plays next week, okay? So expect that during role plays, somebody will be doing problem solving, somebody will be doing the cognitive restructuring of automatic thoughts to restructured thoughts, someone will be doing the ABCs, okay? So just somebody may be doing the food tracking, right? So we kind of, if we go into 5, it might be one person's doing that introduction, the next person's doing, because we would need to build the rapport, right? Next person does the tracking, someone else does ABC. We will do the same way we did last time when we practiced role plays, so it will be fast, it will be a little bit confusing, we'll work together. You're not gonna, if you're doing the intro, you're not gonna be intro for the next one, okay? So I don't want you guys to think like, oh yeah, we'll build rapport, that'll be my role play every time. I wanna make sure everyone gets practice with skills and everyone gets practice with building rapport and everybody gets practice with that kind of relapse prevention at the end. Questions on that?
Actually, that reminds me. I actually do have a question for Meredith. You talked about the stages. Was there literature about, or more literature about the